Started. Hi, everyone, and welcome to Lown Institute's 2023 Fair Share Spending Launch. My name is Dr. Vikas Sani, and I'm president of the Lown Institute. Hospitals are a cornerstone of our healthcare system, and the U.S. has some of the best hospitals in the world. But as hospitals have changed from small charities to big businesses, we're recognizing that quality is not the only thing that matters. It matters, but there's a lot more that matters. For an equitable and sustainable healthcare system, we need hospitals to be socially responsible. So the Lown Hospitals Index for Social Responsibility is the first national ranking to measure health equity and value alongside traditional metrics like outcomes. We have 54 metrics available for more than 3,000 hospitals around the country. Now, one of these metrics is the one we're launching today. It's fair share spending. And that evaluates how much nonprofit hospitals spend directly on their communities compared to their tax breaks, the tax breaks they enjoy by virtue of their nonprofit status. So why do we decide to measure fair share spending? Nonprofit hospitals are exempt from state, federal, and local taxes. That's a benefit that we estimate is worth about $30 billion around the country. But we've seen time and time again that some nonprofit hospitals act no differently than for-profits when it comes to prioritizing their bottom line. For example, our work shows that on average, nonprofit hospitals don't give more in financial assistance than for-profit hospitals do. Some hospitals purposely avoid telling patients about financial assistance and then send them to debt collection instead, as we saw in a New York Times article on Providence Healthcare System last year. Now, this matters because I think most of you are aware we are in the midst of a big crisis in medical debt in the country. More than 100 million Americans are in debt, and most of them owe it to the hospitals. More generous financial assistance policies that provide free care to more patients would go a long way to reducing the debt burden across the country. Hospitals can also give back to their communities through programs that improve health or improve the social drivers of health, like substance abuse treatment, health education, affordable housing, healthy food, and so much more. These investments are desperately needed because we are facing a slow pandemic, many chronic health conditions, and we know that they disproportionately affect low-income communities, communities of color. Now, this year, there does seem to be a changing of the tide because we're starting to see policymakers and communities hold hospitals accountable for their social responsibility. Excuse me. So, for example, state and local officials in Atlanta and the Georgia NAACP recently filed a federal complaint against Wellstar Health System for closing 2 hospitals known for serving the Black community while planning to open a new hospital in a whiter and wealthier area. In Pennsylvania, a court recently decided to revoke the property tax exemptions of 2 Tower Health hospitals because of excessive CEO pay, and they restored $2 million to the local school district as a result. The city of Pittsburgh recently announced that they're challenging the property tax exemptions of some nonprofit parcels, and that includes several belonging to UPMC, University of Pittsburgh Medical Center. And state and local governments elsewhere in Oregon, Massachusetts, New Jersey, and Colorado, and many others are taking action to define higher standards for how nonprofit hospitals give back to their communities. Today, we're very excited to have several health policy experts from some of these states, and they're going to help us review and discuss how we can improve transparency and accountability for nonprofit hospitals. So let's introduce them. So first, Nancy Dolson is the director of the Special Financing Division at the Colorado Department of Health, Care Policy, and Financing. Ms. Dolson directs and oversees hospital incentives, community benefit reporting and analysis, and other programs that serve the people of Colorado. Lisa Frank is Chief Operating Officer for the City of Pittsburgh under Mayor Ed Gainey. She helps residents imagine, build, and maintain a city where everyone can be safe and thrive. Prior to joining the Gainey administration, Chief Frank served as Executive Vice President for strategic campaigns at SEIU Healthcare Pennsylvania. That's one of Pennsylvania's largest healthcare unions. Stephen Ranzoni is Hospital Policy Advisor and Program Manager for the Hospital Reporting Program at Oregon Health Authority. Most recently, Mr. Ranzoni led that program in implementing Oregon's new community benefit minimum spending floor. And Dr. Naman Shah has an MD and a PhD, trained as a family physician and as an epidemiologist. He's currently Deputy Director at the Los Angeles County Department of Public Health. So welcome to all of you. We're really delighted to have you here. So let's start off. Stephen, I'm going to toss the first question to you. Oregon became a leader in this space by establishing some new financial assistance eligibility requirements and some community benefit minimums in 2019. What were some of the issues that drove the state to pass the legislation, and what impact has it had in the state so far?
Hi, thank you for the question. I'm very happy to be here. I think the first very important thing to discuss here is that the transformative bills that we passed in 2019 that you referred to were not OHA's bills. They weren't government driven. They were patient advocate driven, and came out of the community. And OHA was just doing the work as assigned on the bill. And so, and the reason I said that is because I think it informs where the state was at and why it went in the direction that we had. And so our the principal bill advocates behind it, as noted in another state, was our healthcare union, our SEIU out in Oregon, amongst other notable patient advocacy groups. And so the situation that brought a lot of the changes and the big two changes that happened in that bill, we call House Bill 3076 that passed in 2019, was first we very, very rigorously defined requirement for financial assistance. And so hospitals have to provide financial assistance, a level of it all the way up to 400% of the federal poverty limit in Oregon. And then we created the minimum spending floor program where we assign specific minimum spending amount of community benefit that each hospital in the state needs to spend. And so, the conditions in Oregon, why we got there, where we got there, was largely, the impact to Oregonians that medical debt was having in the state. Just a really light, sampling in the time back in 2019 when this bill was passed, an analysis was done. Roughly 60% of every bankruptcy in the state had medical debt. The median pay of the individual with medical debt in the state was only about $36,000. Right. So it was identified as a significant burden and an issue of people in Oregon, particularly those of low income. And so, handpick many other, associated statistics in and around the fundamental issue of the burden of medical debt and the increase in medical debt. So what has happened? Well, our program, only has fully taken effect as of January 1st, 2021. And so we're only entering a period of time where we're just beginning to get the data for the first round of our community benefit spending floors coming in right now. So what we can really say today is that we know that definitely hospitals have been focusing on their reporting. They've been taking hard looks at their categories, what they're spending, how they're spending. There's been a very large increase in the communications that's coming into our office, working with hospitals and asking questions about what is or what is not community benefit, and things like that. And so I think we've definitely seen a notable increased heightened focus in the community benefit practices, the planning, the communication, and the talking in Oregon.
Great, thank you. That's really helpful to know. Let me turn to you, Dr. Shah. Naman, you just conducted a survey on the impact of medical debt in LA County. You just heard what medical debt was doing in Oregon. How is medical debt affecting lives of people in your community?
Thanks, Vikas. Just a small correction. I'm the Director of Medical Affairs, Medical and Dental Affairs here in LA County. So we have a healthcare protection, consumer protection unit, which I think is pretty unique for a jurisdiction. And That unit has traditionally looked at sources of health harms from outright health scams, healthcare fraud. And this is really our first foray into, inadvertent harms that are caused by informal healthcare, which, we believe are the largest sources of healthcare harms. Medical debt, we didn't really have LA County specific data. We're still completing the report, but from what we've looked at so far, it's a huge problem, larger than most of us imagined. California has really been at the forefront of expanding healthcare access through insurance. And while that's a really important way to protect against medical debt, what we found was really concerning. From 2017 to last year, roughly 1 in 10 adult residents of LA County experiences burdensome medical debt. So not just any medical debt, but debt that actually poses a hardship in their lives. And that number hasn't really changed, even while insurance has been expanded. The effects of that burden are similar to that which has been reported nationally. Half of people with burdensome medical debt take on credit card debt. People routinely forego healthcare or picking up prescriptions. It leads to mental health issues as well as food and housing insecurity. Along with this report, we've put together a consumer forum with consumers affected by medical debt, as well as community groups working with those consumers, who've told us even more in stark terms and stories and day-to-day work by our wonderful legal aid clinics who are helping consumers with medical debt, what the real face of this really, really looks like. So based on the really staggering survey results, as well as our consumer voices, we're taking on medical debt, not just as an individual issue, but as sort of as a systemic population public health issue.
That sounds really, really interesting and exciting. I hope you get some traction with that. So let's turn to Lisa Frank. Chief Frank, Pittsburgh Mayor, your boss, Ed Gainey, recently announced that the city is challenging the nonprofit status of several property parcels, including UPMC parcels. What prompted the decision to challenge these institutions' tax-exempt status?
I think the conversation about our charitable sector has really been going on in Pittsburgh for a very, very long time, as long as I can remember. And I think it has to do, to some degree, with Pittsburgh's specific economic history. We're a steel town, and then we weren't a steel town. And what's grown up in the wake of the loss of steel really has been what some people call eds and meds, or what some people call, the medical industrial complex. But when you put all of that together, about 33% of the city is property that is going untaxed, and some of that is parks, and some of that, not all of that, is occupied by charitable institutions, but a lot of it is. And I think our mayor felt that it was just incumbent upon him, as a matter of accountability and good public finance, to have a look.
That makes sense.
Elected officials, there's a lot of elected officials who are charged with having a look. It's just responsible government.
Mm-hmm. Got it. And were the issues of medical debt anywhere in these considerations, or is that kind of a separate bucket for you all?
I mean, I think we certainly think about medical debt. A council person here, Councilman Bobby Wilson, actually just spent $1 million of ARPA money to buy the medical debt off of some of our residents. I think there are big companies that buy big chunks of medical debt and then do kind of pennies on the dollar. And with that $1 million of ARPA money, they estimated that they would relieve 24,000 of our citizens within the city limits of $115 million of medical debt. And so that's what he had to spend. That's what we're doing. It gives you a little bit of a glimpse into what people are struggling with here. We have sometimes seen surveys. We don't have great data. We don't get direct data about it, so we just get peaks. But we know from surveys that workers have done amongst themselves that one survey we saw, maybe half of workers who work for the hospital are carrying medical debt. And, you hear every day just from the people that you talk to, the ways in which they're delaying treatment, skipping medications, taking every other pill. So there's no question that we think that that medical debt is a serious public health issue in the way that Naman was talking about.
Got it. Thanks. So Nancy Dolson, Ms. Dolson, I heard you just had a healthcare affordability summit in Colorado. What were some of the key issues that residents raised, and what are the concerns out there?
Yeah, absolutely. Thank you so much for having me. It's really my pleasure to be with you all here this morning in Denver anyway. Yeah, on March 15th, we held a Health Cabinet Affordability Summit where we had over 700 attendees who were policymakers, advocates, payers, providers, healthcare leaders, and other stakeholders. Joined Lieutenant Governor Primavera, other Health Cabinet executive directors, and other industry leaders. The topics that we spoke about were advancing rural hospital supports, prescription drug affordability, hospital affordability, and keeping Coloradans covered through the end of the public health emergency. And what we heard back from our audience and through the participation in that summit was folks were really excited about making prescription drugs more affordable through Prescription Drug Affordability Board, which we've begun here in Colorado, our value-based contracting, prescriber tool, et cetera. Folks were really excited as well about how we can promote healthier outcomes and reduce disparities, and drive affordability. 35% of folks talked about how excited they are about our hospital transformation program, which is a strategy to advance value-based payments and is really supported by our analysis of hospital financials and affordability in the state. And then many were also really interested in how we plan to keep Coloradans covered as the public health emergency continuous coverage ends, and our plans to really help make sure that we are connecting our Health First Colorado members, which is our name of our Medicaid program, so that they can work through that redetermination process or be connected through health insurance through the marketplace as an example. And one thing that we heard really explicitly as well is there's really kind of a tale of two Colorados, right? So we have big urban centers where we have a lot of large urban hospitals that through mergers and acquisitions, we now have what we would call mega systems. And then there is rural Colorado, where many of the hospitals are operating really on razor thin margins. And we see, some opportunities to really invest in our rural hospitals and communities through like connectivity and health information exchange support and ways to drive access and affordability and keep care local.
Great, thank you. I'm not sure, we have maybe time to sneak in one audience question, and it's related to Pittsburgh. So Lisa, maybe you can field this, which is, do you have a sense of what proportion of the land inside the Pittsburgh proper is tax exempt, either from healthcare institutions or educational institutions?
Oh, I should have pulled that up. I wish I had pulled that up. We have seen a study. Actually, a number of people have done that study for Pittsburgh. It's a lot, because that is where our growth is, right? Universities, medical centers, that is where our growth is. And certainly those institutions are our largest landowners. UPMC is in fact the largest landowner in the city, our largest employers, our largest charitable entities. So it's a big deal.
Yeah,
I can try to send those one of those studies back to you all, and maybe you can include it in your readouts.
That's great. Thank you. I'm just told that the chat had not been enabled previously, but it is now. So those of you who want to get some of your ideas into the group as a whole, the chat's now open. Well, so let's turn now and talk a little bit about the results that we have here at Lown to share today. As we mentioned before, we created the metric of fair share spending to evaluate how much hospitals are spending on their communities in relation to their tax breaks. So if hospitals spend more than their tax breaks, we deem that a fair share surplus. If they spend less, we call that a fair share deficit. So for this measure, we look at the community benefit spending that the hospitals report on their IRS 990 forms. We only include categories that have a direct and meaningful impact on their community's health. These include financial assistance, also known as charity care, contributions to community groups, community health improvement programs, subsidize health services that otherwise aren't profitable, and activities to address social drivers and determinants of health. On the other side, we use an estimate of the value of the nonprofit tax exemption, which we derived from an academic study from colleagues at Johns Hopkins University, where they estimated that 5.9% of total hospital expenses are the equivalent of what the tax exemption is. This year, we looked at fair share spending for about 1,700 hospitals using IRS data from 2020. We found that about 3/4 of hospitals had a fair share deficit for a total of $14 billion. Now that's enough to erase the medical debts of 18 million Americans or to rescue the finances of more than 600 rural hospitals that are at risk of closure. So here are the 10 hospitals with the largest fair share deficits in 2020. Now, you may recognize some of these since they're pretty big names. UPMC in this instance had the largest fair share deficit with more than 200 million. Many hospitals struggled financially during the first year of the COVID pandemic, and that's the year we're reporting on. But we found it interesting that a lot of hospitals with the largest deficits were actually doing pretty well. For example, the hospital of the University of Pennsylvania had about $150 million deficit, but they made more than double that in net income that year. So they did have enough profit to cover their entire fair share deficit, and they still would have been in the black. Cedars-Sinai in LA had a fair share deficit of 126 million in 2020. They also ended the year with about 470 million in net income, and that included 96 million in COVID relief funds. So here are the states with the highest total fair share deficits in 2020. Pennsylvania, the amount of the deficit is enough to wipe out almost all medical debts on credit reports in the entire state. So all this information and more is available right now on our website, lownhospitalsindex.org. So let's turn to our guests and see what they think about these results and what they want to say and comment about it. Lisa, to you, Pennsylvania and UPMC both seem like outliers when it comes to fair share deficits. In fact, by our math, Pennsylvania's total deficit would cover nearly all the medical debt in the state. So as a city official, what do you make of these numbers?
Yeah, this is not the race you want to be winning. I think they're sobering. And I think it is, sort of what prompted, Mayor Gainey and much of our community has been talking about this, as I said, for a long time, to say, we really should take a look. In Pennsylvania, our Constitution, not-for-profits are actually embedded in the Constitution and are, called purely public charities. And there's an elaborated test called the HUP test that lays out the criteria for being deemed a charity, in the state of Pennsylvania. And those criteria are pretty strict. And they're not only about money. They're not only about, well, your taxes are worth this, but your gift is worth this, because there is taxation is about money and it's about spending, but it's also how communities self-govern, right? We all put a little bit in and then we get together and we hammer out how we're going to spend it. There's an element of democracy there. There's an element of sort of civic accountability there. And so the HUP test talks about, well, what is the value of the contribution? But it also speaks to some criteria that are about the accountability and making sure that if you are going to be carved out of the putting in, duking it out, making decisions, then you have to relieve government of a burden. You can't choose any gift that you'd like to give and have it count. You have to not exhibit the profit motive, and you saw that in the Tower decision, because if there's profit there, then you're participating in the community in that way, and the community deserves to tax that and see some of that. And so when I see those numbers, I think not just about stuff, but I think of the just command of resources that unaccountable organizations have. And I think that's part of the problem that we have to solve as well.
Got it, thanks. Naman, we saw some hospitals in LA have some fairly large fair share deficits. You're an epidemiologist and you're at LA County Health. So what are some of the key health issues in the county right now that hospitals could be investing in?
Thanks, Vikas. I think more than the key health issues, which are important, the mechanisms by which community benefit investments get decided is also important. One of the feedback we heard from a lot of consumers and consumer groups is that they'd like to have more of a voice, more of a stake in the process. And every single hospital, the way they do their community health needs assessment and their community health investment plan, it really differs. That's a problem when you have a lot of overlapping areas of service. We have 77 general acute care hospitals here in LA County. And so that's a lot of coordination to do and a lot of redundant work. That said, there is a wonderful initiative that has been going on for several years that the department is a part of called the LA Partnership, where hospitals are trying to coordinate their community benefit investments, at least a portion of them, into a focused area, which they've decided should be homelessness, which is a large problem here in the county. So I think that is a wonderful mechanism by which to make community benefits more impactful. But in addition to what we spend it on, a really important question is how much is being spent. And I think that second part of increasing the size of the investments is an area of work that we need to focus on.
Great, thank you. Nancy, turning to you, some of the hospitals at the top of our list actually ended the year with healthy net incomes. That's 2020. Now, is this something you've seen in Colorado in your work? Does your department have research on this and hospital finances? Or what are your views on that?
Yeah, absolutely. And thank you for the question. So in addition to examining community benefit spending, the state has also been looking at hospital finances, as you say. We had legislation passed in 2019, and then there's a bill that expands upon that this year that helps us get more financial data and hopefully more timely data with the new legislation that's coming through. Because as I've mentioned, we've noticed, over the past decade, really a lot of mergers and acquisitions resulting in these really large, we sometimes call them mega systems, mega hospital systems in Colorado, particularly in the urban areas. And as we've done our analysis on their financials and done our reporting on that, we see that Colorado hospitals have ranked in the top 10 compared to all hospitals in the nation in each of the years 2018 through 2021 in both their prices and in their net income or profits. And that high ranking is both on profits on patient care, as well as their total overall profits, which includes investment income. In fact, in 2021, at that point, we were fourth highest in patient and total profits. We've seen that the kind of the hospital cost of providing care has improved, but the prices haven't. So we are examining both the prices and then as well as what's coming back into the community. And just to underscore that, the net income for our nonprofit hospitals in Colorado was 14.5% in 2021. So really great points being made by my fellow panelists about how, what is really coming back in the community? What's the value of that compared to their profitability? And then we've looked at some preview data for 2022 through the first 3 quarters, looking at those systems that are operating in Colorado. And even with the stock market losses in 2022, we see our system hospitals still have healthy reserves. So UC Health, which is a large nonprofit hospital system here in the state, which includes our University of Colorado Hospital, had $5.1 billion in reserves in September. And Intermountain Health, which just recently acquired SCL Health Hospitals in Colorado, has $11.1 billion in reserves. So absolutely, we see those healthy incomes, and it, begs those questions that we're asking today about what is the benefit that's coming back to the community from these nonprofit tax-exempt hospitals.
Great. Stephen, Oregon, I understand, got some pushback from hospitals when the reporting was first required. I think one concern was that the reporting burden itself might be too much. So how's that played out in the last year or two?
Yeah, I think interesting to juxtapose against what we just heard from LA County having 77 hospitals in just the county. Oregon has 60 hospitals in total. 33 of those 60 hospitals are a rural hospital. 25 of them are critical access hospital, have less than 25 beds, or, in a fairly remote situation. So we have a very, disproportionate landscape, inequitable landscape across our hospitals. And so, as charged in the bill, we needed to do an assessment and report to the legislature. This past year is due back in December. The status, the implementation status of that bill that we passed, 3076, and see how well the provisions of that bill, the financial assistance provisions, were implemented, how well the minimum spending for program was stood up, and all that. In the course of putting together that report, we interviewed, a lot of hospitals in our state, and asked them a series of questions what's going on. And one of the things that we definitely heard from our smaller hospitals and our rural hospitals was, in order to start meeting the standards, they had to actually have a community benefits person for probably the first time in their history, right? They had to hire staff. So there is no way to avoid the conversation that, yes, it was an administrative burden for some hospitals, particularly our small ones. They had to hire a staff that they didn't typically have. The way that it is for most of these hospitals is the CFO wears all hats, right? And does the community benefit work and puts together our reports at the end of the year when they're due to us. And so I can say, we did have several hospitals that did report back to us that, hey, wow, this is actually kind of cool that we now have a staff person doing this stuff and organizing this stuff and helping us, start thinking forward and being proactive. And so how it's played out is, I think, for a large swath of our facilities in Oregon, there has been something that we really have wanted to see, and that's a shift to proactively thinking about community benefit, not doing an accounting exercise at the end of the year, trying to tally up everything that has happened, but really think forward and go, what are investments we can make? What can we take off our community needs assessment? How can we actually start putting planning and stuff into this, report it out, meet our obligations, and help our community? So there's definitely been good. So I don't want to undermine or dismiss, the concerns our hospitals brought up, because yes, it is burden. We are asking of and demanding more in terms of how, community benefit practice happens in the state, but I think it's bearing fruit and it's showing positive results for sure.
And did the legislation take never mind the administrative burden, but the financial burden of hiring somebody else? Was that all on the hospital's dime? Was there any?
Yeah. There's no carve out or general fund allotment or anything like that. It was, generally speaking, it was hospitals, you need to do this, go forth. And they had to handle that. Yeah.
Great. Well, related to what you were just saying, we have a question from the audience. An anonymous question, I'm not sure from whom, but the person makes the point that not all expenditures in a meaningful list are actually created equal, nor, according to some research, are they necessarily aligned with community health needs assessments. Some might fairly be described as primarily PR or image burnishing. So the question is there any more research into this question, this alignment question? Naman Shah mentioned a little bit, some of the issues and concerns in LA County that were expressed by citizens, but this is really for any of you or all of you. How do we define meaningful, and is there a path to developing some standards for what is actually meaningful for a community and not simply either an accounting exercise, as Stephen said at the end of the year, or a PR exercise? Lisa, you're nodding your head. I'll give you the floor.
I think these are really substantive questions. I mean, we in addition to tax exemptions, right? We got Medicare, we got Medicaid, we got veterans benefits. We have a lot of public investment in institutions, and even calculating something like net income. Well, net income after we've built a new building, is it net income? In the for-profit world, you have shareholders, right? And there's a shareholder meeting and people, at least in theory, get a little bit of a vote, right? And, and in government, people make a decision. And if you don't like it, you kick them out and you get a new group. not charitable institutions live in a kind of gray area, or in a middle ground between that, where, I mean, the degree of accountability relative to the public investment is really kind of remarkably teensy. And so we had actually a little bit of a sort of thing about this around a project. And it happened to be a UPMC project. They were going to build something new up on one of our hillsides. And it was a big enough change that it required, a change to the master plan. And so there could be some public engagement. And one of the things that came out of it was that the proposed project, medically very, very important, right? It's a hospital that is an eye hospital that would specialize in macular degeneration. Important thing, people have it. Not enough of that going in Pittsburgh to support an entire, patient. And then we similarly had the community benefits. What is it called? Plan that the hospital had done, which put eye concerns about 50th on the list. What was first on the list, as you could imagine, would be primary care, mental health, and so on and so forth. And so it sort of stimulated a discussion about the investment of these public dollars and whether there could be a broader conversation about what we're doing with all of this money and how do people really think about how we use it to generate health. And I think one of the, to me, big facts that we would want to start with is that for all of our investment, the, kind of most, bold and gross indicators of health, right? Mortality, those kinds of things have actually been declining in the era of hospital consolidation, hospital building, hospital, what does that tell us? And how would we want to think about these decisions and who's making the decisions and in whose interest they're making the decision? So to me, this is a very wonderful question. I think it's a very important question. I think it's something we should all be talking about a lot more.
Great. Well, as therapists like to say, our time is short. Let's turn to solutions. We don't have a lot of time, but let's get into this. This is a huge topic. Obviously, it's part and parcel of why you all are here with us today, either having solutions or tried some solutions or seeking solutions. So let's talk a little bit about what hospitals can do to fulfill their social compact, legal or not, what they can get away with versus what's the social compact, and how can policymakers give them a nudge in that direction. So Stephen, the Oregon legislation is pretty innovative. You're the only state that creates a minimum spending floor for each hospital. And my understanding is it's different for each hospital. It's not one formula. How hard would it be for other states to do what Oregon did?
Well, that is a tricky question. I want to probably naively say, I don't think there's any reason any other state can't do what we're doing. To be sure, our methodology isn't, complex rocket science or anything like that. We set forth, we had criteria spelled out by the legislature as to how we were to develop a methodology. We took, one thing that Oregon had in its benefit is a long-lasting and existing community benefit reporting program. We started collecting community benefit data back in 2009. We actually predate the ACA. And so we had a lot of data already on our hospitals for us to work with, to go back in time, to model, and to help us develop a methodology with which we were to use to apply to hospitals. But with that said, again, we are not highly sophisticated in what we do. We adapt, the secret to what we're doing with all our hospitals is just adapting to each one's situation and primarily their financials and their trends. Right. And so can other states do this? Yes, absolutely. Any state can do this. The challenges are unfortunately something that I don't really have the leg to stand on, and that's the political wins in each state. That's the conversation. It's the making the sausage of policy for each state, and whether or not this is something that the legislature in the state wants to see, whether or not the patient advocates in the state want to see, and whether or not the hospital association in the state is going to want to see. And so that, nothing I can answer there. But in terms of how we have functioned in Oregon, is this insurmountable? Is this too difficult? Is this too hard? Absolutely not. We did it.
Got it. So Nancy, in that vein, I understand there is some proposed legislation in Colorado, but what would that legislation do?
Yeah, absolutely. Thank you for the question. So we do have a bill making its way through the legislature as we speak. I think it's on its final hearing in the House to move over to the Senate, and that's our House Bill 23-1243. And this is really expanding on legislation we passed in 2019. The 2019 legislation requires our tax exempt hospitals to hold an annual public meeting, discuss their community benefit implementation plans, as well as to report data directly to us about their spending. But that 2019 legislation really, the reporting is really in big buckets: charity care, health programs that address health needs or disparities, health programs that are addressing social determinants of health, and then other. So we have kind of these four big buckets. And what we haven't been able to do is really be able to investigate how what the hospitals are spending discretely is tying toward those community voiced needs, right? We see as we review their community health needs assessment that 95% of them say behavioral health, but as we dig into the data that we do get, that's not what we're seeing. So the legislation this year is going to do a few different things. I'll say, unfortunately, Stephen, it does not have a minimum spending. That was something we really worked hard on with our advocate partners on this bill, and we were just not able to get there. But it does help further increase that transparency and accountability. Specifically, will require more specific and detailed spending information. So instead of those four big buckets, be able to get discretely what was spent on behavioral health, what was spent on food supports, et cetera, what's spent on research and training and provider education. And so that way the communities can really have that tie. What were the activities and initiatives funded? How does that compare to what we asked for? Also going to explicitly require them in those annual meetings to solicit, consider, and provide the community opportunity for feedback in creating those annual spending plans, and especially in any changes in those spending priorities. And then something that I'm pretty excited about, even though it is really on our agency, is it's asking our agency to really undertake stakeholder work to develop community engagement best practices and efficiencies, so that we can really get the voice of the community at the center and really get good involvement. I think we all are probably familiar with, kind of stakeholder fatigue of people being surveyed or invited to a lot of meetings. So we're working on that. And then finally, going to require our state auditor office to calculate the value of the not-for-profit hospitals tax exemption, so that we can, us and our communities, like what y'all do with your reporting, we can see what the value of that tax exemption is compared to their spending. So a lot of big things. It's on the way to the Senate, and hopefully we will have this further legislation enacted here before too long.
Great. Lisa, you gave us a little bit of the debate around that. Sounds like a medical or a tower for macular degeneration. I never would have imagined that myself, but there you go. So what's at stake in Pittsburgh if things don't change, given what you're hearing is bubbling around the country?
I think people want to live in a community that's fair, and where, our residents, they put their money in the pot, and we got a lot of stuff that is underfunded that they want to see done. And so they get some things done and they live without some things. They are not as healthy as I think they should be, given our investments in healthcare. I think it's the same as everywhere. I think we have enough to be a healthy and thriving people. I really do. I don't think our problem is scarcity. I think our problem is how we arrange ourselves, and who does what and who doesn't do what, and who is at the table for some conversations and not at the table for other conversations. So I think it's nothing short of the health of our people, and and Mayor Gainey wants to start to have that conversation, and I know the people of Pittsburgh do, and all of you do. I think it's a conversation that's very ripe.
Great. Naman, The medical debt situation in LA that you were describing, to what extent are hospitals in LA County aware of it? What's their response been so far to this crisis? Has there been a public response, and do you anticipate there will be as your own report comes out?
Great question. So we just had our first forum on medical debt with the healthcare community, including hospitals, clinics, and health plans last week. We had a tremendous participation and a strong commitment towards a coalition that would continue working on this in a longitudinal fashion. Similar to what a lot of other people have said on the panel, information and conversations are two key elements. And, we think that conversation needs to be sort of a three-way conversation between hospitals, between sort of local government and policymakers, and then, residents at large. A big part of what helps conversations is data and awareness. And this came out from a number of conversations I've had with hospitals, both internally. Sometimes leadership's not necessarily even aware of practices. One of the examples that was given is there is actually a fund that annually is required to pay for inpatient admissions in a certain catchment area that was created after a nonprofit to for-profit conversion of a specific facility. And among the 12 hospitals in that catchment area, there's varying degrees of access to that funds. And in fact, every year, the fund amount is not fully spent. And those same facilities are often still collecting debt from individuals, which they have money available to write off. So there's a communication gap. Data, again, it's important. It's not a silver bullet, but it is a wonderful conversation starter, both for internal conversations and conversations at large. So we're going to move forward with some of that.
Great, thanks. Let's turn to some more audience questions while we have some time. So there's a question from Carla Sampson. Might we see more support or calls for pilots from hospitals? For those of you who don't know, pilots are programs that it's an acronym for payment in lieu of taxes. My understanding of that is instead of a formal taxation system, an informal kind of levy based on the fact that, you use the water, you use the police, you use the fire, that's got to be worth something to you. Thoughts about pilot programs? Anybody? Nothing. That's interesting.
I'll say many hospitals have them. Hospitals that operate in Pittsburgh don't have them in Pittsburgh, but have them in other municipalities in the state of Pennsylvania. So it's certainly an instrument that people have used. I think they are useful in one way that, perhaps a community benefit is training a doctor is a fantastic thing, doesn't fill a pothole. So, there is a pilot addresses that problem. I don't want you want to call that the sort of unequivalency thing that can happen when all of the gift comes in the form of a community benefit. So I think those are reasons that people have sort of seen that tool and picked it up and thought to use it.
Yep. I think that we'll go through several more questions, and if you have them, keep them coming. Here's more of really a comment, and I guess it may be addressed to me, but earlier Wellstar in Atlanta was pointed out as a subject of scrutiny from lawmakers and advocates for closing 2 hospitals that served Black communities in Atlanta. However, 2 Wellstar hospitals are listed in the top 25 with the largest fair share surpluses. What are some thoughts on this? I will certainly take a shot at it from my perspective. I think what it shows is a couple of things. First of all, you have to think about hospital systems, and when you do, there's a lot of different hospitals and hospital systems. They're in different communities. Their local and regional management may be one thing. The health system management may be something else. There's a lot of stuff that may not be fully aligned or reconciled, or it may simply be that in certain areas and locales, they're doing a great job. I think, what Lisa said, I think is important for all of us to understand, which is there's a lot of money. It's just not perhaps distributed in a way that optimizes everybody's health. And that's kind of at the heart of the matter. So it doesn't surprise me that a large system would have some hospitals that do really well and others that don't. The real question is, how can we get our entire system, not just a given health system, but really all hospitals in the country, rowing in the same direction so that we begin to see some of the benefits that we know are out there in terms of health, the health of communities. Anybody else want to comment or have anything to add to that? Okay.
I'll just say, because that it highlights that multiple, motives and actions can coexist in the same space. You can do good and you can do harm at the same time. I mean, our hospitals have been tremendous partners for us throughout COVID. And, even some of the hospitals that have fair share deficits on the Lown metrics, it doesn't really reflect the different ways they've stepped up to be a part of the community and assist us in our, specific responses. So I think the sort of old medical maxim of first do no harm is important to remember here. A lot of value creation, a lot of wonderful work, but at the same time,
couldn't agree more.
To just certain, what Dave Chokshi, the former New York City Health Commissioner, has called never events. And some of the never events and sources of harms that we're interested in also making sure don't happen here in LA County, hopefully, include sort of new and emerging practices like outsourcing, patient financial assistance programs to, private equity companies, or, workarounds from against the new surprise billing laws. So there's ways to extract value, which we, all facilities should avoid, and really focus on the core value creation that they do.
And I'll just throw in the equity lens there is really, really important. I mean, there, similar thing happens, like, closing a hospital that is primarily used by African-American residents and is the prime, employer in, say, Braddock, Pennsylvania, and then being a good community partner in a more well-to-do suburb. That you can't put those two things in a scale like this and say it evens out. So I think looking at the system's performance as a system through an equity lens is really important.
Yep. Stephen, where would you like to see Oregon go next to build on what you've got so far?
The legislation that passed, was very specific, and it highlighted the social determinants of health, and then highlighted that as a focus of this bill. And so I think the very succinct answer is continuing to work in a way with our hospitals and with our partners to promote a continued focus in the social determinants of health spending. That is continuing to be proactive, continuing to leverage and use your community health needs assessments, continuing to actually identify what your community needs, and coming up with a plan to actually react to that and improve the health situation in the state. And so I do think that that's the big picture, really tied up. I think one comment I want to add into this, especially as I'm hearing the other conversations, is it's a really challenging policy position to think about what a health system is doing at a whole and what an individual hospital is doing at a whole. Because the issue of taxation, the issue of replacement value, the issue of nonprofit hospital is the local community, period, right? The hospital exists in a town. And so I think that we cannot lose sight of the individual hospital and what an individual hospital has to do to its community, period, right? Regardless of what the greater health system is doing or how great the health system in itself is, the fundamental issue is that a hospital needs to be there for its community and participate in that community. And so I really do, one of the reasons I like what we do in Oregon, I like our minimum spending floor, is that we adapt to each individual hospital and its needs. We have hospitals that are so small, their number one priority is keeping the doors open. Being the one hospital for a 100-mile radius of Oregon so those patients can be there. And so we can't have an expectation that they're developing some grand, affordable housing plan in their very small town of 2,000 people. We expect their, emergency room stays open 24 hours. Right. But that is absolutely not the case for our greater Portland metro area hospitals. Right. And so, looking forward, it is the social determinants of health. It is meeting the need of the community and continuing to just work together to focus on that, highlight on that, and move forward with that as our goal.
Great, thanks. Nancy, what other policy actions do you think should happen in your state in terms of community benefit spending?
Yeah, absolutely. And I think I'll just very much be building right on what Stephen and Naman and Lisa have been saying for sure. And that is really, we want to continue our work to really look at the overall value proposition that the hospitals are bringing to communities in terms of prices and affordability, what benefits coming back to the community in lieu of the taxes, right? And their obligation there. And then how is that advancing quality? What are our health outcomes? How can we be moving through with value-based payments and other efforts that we have within our agency to help improve quality and health outcomes. And then again, I just want to circle back, and Stephen, you were just speaking about this very well as well, which is around rural hospitals. Very different needs in rural areas of the state. Got those large systems with incredible profits, not really clear about if that community benefit is really meeting the needs of the community and takes on the value that the community is expecting. And then we have rural hospitals, including 2 pretty recently, that have really run into some financial concerns. So how do we support those rural hospitals, keep those available for those communities, and make sure that our urban hospitals are being accountable to the communities that they serve?
Great, thank you. A couple more final questions. One, I don't know who the questioner is, but without specific legislative criteria for performance, hospitals and their executives are not and cannot be held accountable for their outliers. What are your thoughts on the need to develop specific criteria and consequences to hold executives accountable? So I guess you could, we don't have a lot of time, so maybe just very quick lightning round. Really the question is, what's the carrot, what's the stick? How do you actually get to an enforceable set of rules and regulations? That's how I'm interpreting that question. Lisa?
I think we have attorneys general, we have federal agencies that are looking at hospital systems. I think we have lots of tools, and what I've seen happen here is those actors have some real authority to intervene and tell hospital systems how to behave. Most famously here by forcing them to take each other's patients when they didn't want to. So I don't know, a bigger toolkit maybe than the question implies.
Mm-hmm. Stephen, what's your view?
I think anytime you can do something without passing a law, it's ideal, because passing laws is really hard. But sometimes you need the framework of law. And I think to the heart of the question, it's hard to enforce when you have no boundaries. So.
Got it. We are out of time. So quickly, Naman?
I think there's, like Lisa said, there's going to be a variety of options, and it's going to take more information and conversations to get there.
Nancy?
Yeah, absolutely agree. And one thing we are also looking to get is the CEO and other executives pay, as well as for the CEO, what those performance standards are. What are they being held accountable to? Is it growing their market share, or is it benefiting the community? So first starting with the information and then using the tools that are available.
Great, thank you. Well, let me wrap it up. A last question for me, I think, is do you, or maybe for anybody, do you see any impact of the Lowndes Fair Share Index on hospital behavior? And my answer would be not yet, and certainly not as much as we'd like to see. But our theory of change really is that if we can change the framing, if we can change the terrain, if we can change the temperature, that there will be plenty of people who will step up to help make that change possible, including our esteemed panelists here today. They're all playing a role, and I think there'll be more of that. We've heard a few rumors that are just rumors about hospitals that have suddenly found money that was hard to find previously. So, maybe some of that has to do with the climate. So let's see. So a big thank you to all of our guests, Nancy Dolson, Lisa Frank, Stephen Ransoni, and Naman Shah. For more from the Lowndes Institute on all things hospital and hospital social responsibility, please subscribe to our new monthly newsletter, Hospitals on Purpose. Thank you all for being with us. See you next time.